Good morning, everyone. I'm Deepti Ramachandra from Mumbai, India. I'll be presenting our algorithm for portal flow optimization in cirrhotics undergoing liver transplant. As we all know, establishing portal flow is the cornerstone for a transplant to be successful. Presence of portosystemic shunts or collaterals can make it difficult during transplant, and it is usually seen in about 40%. The common shunts are the splenorenal, gastrorenal, or the left coronary ones, and less common being retroperitoneal or inferior mesenteric collaterals. Our study aimed to propose an algorithm for optimization of portal flow in patients who have spontaneous portosystemic shunts or collaterals undergoing transplant and to assess its impact on postoperative outcomes. So we have analyzed 392 patients over 3 years, and we have utilized contrast-enhanced CT scan, MRI, and Doppler to guide its management. As we all know, these portosystemic shunts are natural shunts formed because of portal hypertension, and they usually close a couple of weeks after transplant. And also in scenarios where there is graft edema, such as hepatic venous outflow obstruction, regeneration of the graft, rejection, and graft dysfunction, these are the conditions which will keep the shunts patent even in the postoperative period. Let's quickly take a look at the advantages of having these shunts. They tend to decompress the portomesenteric system during hepatectomy and decrease the blood loss, as well as prevent bowel edema. It is also postulated to prevent hypoperfusion syndrome in small partial grafts. Whereas the disadvantages being, it is known to have increased portal vein complications postoperatively, as well as cause flow diversions and cause steal phenomena, thereby leading to hypoperfusion and graft dysfunction or failure in severe cases. Hence, it is very important to have a good preoperative imaging and mapping. So in order to have this, we need to have a good contrast CT or MR to look for status of the portal vein, whether portal vein there is thrombosis, attenuation, or atresia. We also need to map the collaterals and shunts so that if need be, we would have to address them. We have also utilized preoperative Doppler to guide management. So we have classified the shunts into surgically accessible shunts, which would be splenorenal, gastrorenal, or enlarged coronary vein, and right paraduodenal shunts, whereas the surgically inaccessible ones are the mesogonadal, mesocaval, right and left-sided retroperitoneal shunts, as well as shunts which are draining into the left renal vein, which is coursing posterior to the aorta. Who requires this intervention and when? In the preoperative period, if patients have a abnormal Doppler and the shunts are inaccessible surgically, and if they have large shunts draining into the left renal vein, which is coursing posterior to the aorta, these are the patients who would require preoperative IR intervention. And during surgery, if we feel that after hepatectomy, there is subjectively a low flow of portal flow, and PSV is after implantation, if the PSV is less than 30 centimeters per second or volume less than 100 ml per 100 gram, and they have surgically accessible shunts, these undergo surgical ligation or intraoperative intervention. And patients requiring postoperative intervention are the ones who develop graft dysfunction or abnormal portal flow values during the postoperative period. These undergo either surgical intervention or IR guided intervention. So let's quickly look at patients who underwent preoperative intervention. This is a patient who had low flow, low volume on preoperative Doppler and had a large left renal, splenorenal shunt joining the left renal vein, and which was coursing posterior to the aorta. Since it was inaccessible during surgery, we opted to embolize this plug-assisted embolization of the shunt was performed preoperatively. This is another patient who had a large gonadal runoff, which was picked up on CT scan during the preoperative period and underwent parto. So for patients who have an abnormal Doppler in the preoperative phase, this patient had no flow on color Doppler and low flow on spectral Doppler and had a large splenorenal shunt. And after implantation, the flow was not satisfactory. Hence, we did a trial clamping of the shunt, and portal flow and velocity increased, and thereby patient underwent ligation of the shunt, and postoperative Doppler was normal. This is our method of dealing with grade 3 PVT. We use pharmacological thrombolysis and balloon maceration if we are not able to get good portal flow with eversion thrombectomy. Patients who require post-operative interventions are the ones who develop graft dysfunction or abnormal portal Doppler findings during the post-operative period. I'm sorry, I don't see the imaging, but this is a patient who had normal Doppler on POD1 and POD6 developed reversal of flow in the portal vein as well as hyperdynamic artery. So we went ahead and did a cross-sectional imaging and found large subcutaneous collaterals, which was not so enlarged during the preoperative period. So patient underwent surgical ligation, and post-operative Doppler was normal. This is another patient who had graft dysfunction, and we found that he had a mesogonadocaval runoff and underwent plug-assisted occlusion of the shunt. So in our patient cohort of 392 patients, 336 required no additional intervention at all, and 56 patients required intervention, of which 54 were LDLT and 14 were pediatric LDLTs. So their median MELD was 22, and 30 patients had a significant shunt diameter that is greater than the portal vein diameter, and 21 patients had PVT, and PVT with significant shunt was found in about 10 patients. So whenever patients have portal vein thrombosis, initially we do eversion thrombectomy, and after that any augmentation procedures are performed. And this is the table which depicts different augmentation procedures. So after analyzing our data, about 14.2% of the patients required portal flow optimization after initial thrombectomy. One of the patients had rethrombosis, and 3 patients had graft dysfunction because of steel and underwent postoperative IR-guided intervention. No patient had hyperperfusion syndrome, and 4 patients had early allograft dysfunction. 3 were because of portal steel phenomena and 1 because of sepsis. And postoperative ascites more than 1 liter was seen in 6 patients, and it was predominantly chylous, and we had 3 mortalities. So different centers around the world consider different threshold of shunt diameter as well as portal flow and pressure measurements to augment portal flow. In countries like Japan and Korea, they prefer to ligate the shunts, create a control situation, and then modulate. In India, some of the centers measure both flow and pressure, and then take a call on augmenting the portal flow. At our center, we have utilized subjective and objective assessment of portal flow and no pressure measurements. This is our algorithm. Once a patient is worked up for a transplant and contrast imaging is done, if there is no problem with the portal vein, then patient undergoes a standard liver transplant. If patient has PVT, then thrombectomy, and then we assess the portal flow. Or if it is attenuated portal vein, either we do a plasty, portal vein stenting, or we put an extension graft. If the flow is still not adequate, then we address the portosystemic shunts or collaterals if they were not addressed in the preoperative period. And also, if patient develops graft dysfunction in the postoperative period, then patient undergoes surgical or IR-based intervention. So the take-home message would be that all shunts or collaterals need not be addressed. Preoperative mapping and planning along with intraoperative assessment of portal flow is the key. Portal flow optimization should be performed after thrombectomy. Intervention can be tailored according to adequacy of portal flow, location, and shunt diameter. Thank you for your patience.